treatment of hormone receptor HER2 advanced breast cancer. We've got Professor Hope Rugo, Professor of Medicine and the Director of the Breast Oncology and Clinical Trials Education at UCSF, Helen Diller Family Comprehensive Cancer Center in San Francisco in the USA. It's always a great pleasure to be with Professor Hope, who actually is very, very generous with her knowledge in sharing it with us, especially here in Egypt. We've also got Professor Ahmed Hassan, who is a consultant of clinical oncology at Ain Shams University, working also as a consultant in the NHS New Cross Hospital, and Professor Mohammed Sabri Al-Adi, a professor of clinical oncology and a great friend of mine from Ain Shams University. So the exciting news about this 5 years transformation is that we always have to remember that it was in 77 or 1977 where hormone receptor positive breast cancer was the first marker-driven cancer therapy when tamoxifen was introduced. And going down the line there, you only started to see targeted therapies coming in 2012. And with those M2 or CDK4/6s and the PI3 kinase approvals coming in forward. And with that, we can see that most of them, or some of them, have added on benefit in the advanced breast cancer in these hormone receptor positive breast cancer patients, whether it is the PFS benefit or the OS benefit, as we'll be hearing. This is the news that has come in just a couple of years ago. The overall survival benefit results that were being shown with the Mona Lisa trials, as well as with the Monarch trials and the Paloma trials. And I think Professor Hope will be going in deep into that. And this is why we are seeing that after this PFS and OS results, the CDK4/6s have become the preferred first line, as well as sometimes in second line or next line therapies in these hormone receptor positive breast cancer patients. And the condition that taking these CDK4/6s may or could help in control the cancer longer. And we've heard an extensive session on this prior to this lecture that was actually proved quite a bit or quite more a lot interesting. The new innovation, I think, and that's again to say that it has come in after 42 years, the new biomarker-driven hormone receptor cancer, positive breast cancer patients, biomarker-driven, has been the PI3 kinase inhibitor with the introduction of alpelisib being approved based on the PFS benefit that was shown in 2019. So it has been a long time, of around 42 years, before we've had another biomarker-driven hormone receptor positive breast cancer treatment management, and that's why again PI3 kinase inhibitors, and namely alpelisib, has been preferred in sort of the second line or next line therapy for these hormone receptor positive breast cancer patients. And it's going to be interesting when we're going to have cases after the lecture from Professor Hope to get Professor Ahmed Hassan and Professor Ahmed Sabri to talk about both premenopausal patients and postmenopausal patients, because we as oncologists always used to think that premenopausal patients are sort of totally different from those postmenopausal patients in hormone receptor breast cancer. So having said that, I'm going to hand it over to Professor Hope to go on with expanding the evidence base with PI3 kinase inhibitors. Professor Hope, please.
Thank you very much for that kind introduction, and I do apologize just because everything is a little bit late this morning. I have clinic, so we will have a Meet the Professor session tomorrow morning and talk about some more of the cases, but I probably will leave you to discuss the cases to get my patients to chemotherapy this morning, it being morning in San Francisco. So it's a great pleasure to be here, and let's see if I can get this. You can all see the slides now? Yes? Just checking if you can see the slides.
Yes, we do.
Okay, great. Just wanted to make sure that you could hear me and see the slides. Okay, so I'm going to talk about PI3 kinase inhibitors in more detail. We certainly talked about them a little bit in the prior session as well as biomarkers, but now we're going to talk a little bit more about just the PI3 kinase inhibitor that's approved, alpelisib, how it can be used, and a little bit about management of toxicity as well, some of the new data that we presented in 2020 that will be published soon, and some data, the SOLAR-1 overall survival data, which was just published in the last few days. So it was very good timing for this meeting. So this shows you 2,433 primary breast cancer samples from Nature Communication 2016. And what you can see is that if you look at PI3 kinase, so here's PIK3CA mutations down here, you can see that this is going to be the most common mutation seen in the patients who have ER positive disease. In patients who have, this is ER negative disease, sorry, and then in ER positive disease, you can see this is well over 40%. This is grouped into an area called AKT signaling, but what's interesting is AKT, PTEN, et cetera, are much less frequently altered compared to PIK3CA. This alteration in ER-negative disease is quite interesting in the yellow down here, and is trying to be capitalized now in studies looking at combination of alpelisib with chemotherapy in the first-line setting. And as you know, we just saw the results from one of the opportunity trials looking at paclitaxel and the AKT inhibitor ipatasertib that did not show a benefit in patients who had alterations of this pathway. So where we understand that alterations in the PIK3CA gene are most important is in ER-positive disease at the moment, and we'll see more data on this in ER-negative disease in combination with chemotherapy. In the future, there's an ongoing capivasertib trial with chemotherapy, and both phase 2 trials with these two agents showed a suggestion of survival benefit. If you look at the other most commonly mutated gene, TP53, the loss of a tumor suppressor gene, what you can see actually is that this is less commonly altered in patients with ER-positive disease, but very, very common alteration in triple-negative disease, as we're all used to seeing. So if you were to just stand back and look at this, you would say, okay, what can I do to target a particular pathway in breast cancer? And what would immediately stand out to you, given the fact that we can't yet target the tumor suppressor gene loss, is that we should target PIK3CA. So lots of different studies have been done to try and look at this. We know that mutations in PIK3CA lead to PI3 kinase pathway hyperactivation, and that this contributes to endocrine resistance. We've seen in the metastatic setting that patients who have alterations in PIK3CA have a worse outcome and a shorter progression-free survival with therapy, although they appear to benefit to the same degree with the addition of CDK4/6 inhibitors. They have a shorter PFS in both arms. So about 40%, as I just showed you, of hormone receptor positive HER2 negative advanced breast cancers have mutations. Interestingly, although in the advanced breast cancer setting, this mutation is a negative prognostic factor, there's actually data from early stage breast cancer from one of the large adjuvant aromatase inhibitor trials, the letrozole trial, that suggests that patients, as well as other preceding data, that suggests that mutations may confer a relative benefit in terms of prognosis in early stage disease. Whether or not that is because of their bedfellows, in other words, are there other factors that go along with having a mutation up front, we don't really understand. But certainly having a mutation in the early stage setting is not driving our treatment at the moment. So as I mentioned, there is negative prognostic factors from this. This represents a negative prognostic factor as seen in the trials that we've looked at with a variety of different therapies in hormone receptor positive disease. So although you benefit from CDK4/6 inhibitors, overall PFS is shorter in these tumors. And then in the Bolero-2 trial with everolimus, these patients benefited from everolimus but had a shorter overall PFS. This is actually really interesting data from the SAPHIR-2 trial from France, looking at patients who had mutations in PIK3CA or not, and looking to see what happens in terms of response, et cetera. And if you see here, what you can see is the gray is actually response or stable disease, and the blue is death or progression in the follow-up in this trial. And what you can see is that these patients overall had the patients who had mutated disease, although a smaller number, had a much lower chance of response than patients who had the wild type of this gene. And then if you look at the median overall survival here, you can see that it is moderately shorter in patients who have a PIK3CA mutation. Very interesting. And these were patients who had received chemotherapy. So it does hold true even as you go past endocrine therapy. And then this shows you in Paloma-3 the PIK3CA mutation status in response to CDK4/6 inhibitors. What you can see when you look from the right to the left is that these curves are shifted down. So as I mentioned earlier, hazard ratio almost identical, 0.48 and 0.45, wild type here on the right. But overall, in the group that received fulvestrant or fulvestrant, here's fulvestrant or fulvestrant plus palbociclib, the PFS is relatively shorter. So selective inhibition of PI3 kinase alpha is really what we're going to focus on. In true oncology form, we started out studying the targeting these mutations or activation of the PI3 kinase pathway by looking at pan PI3 kinase inhibitors with the idea that more is better. But as we've seen in many areas of oncology, more is not always better. And it turned out that the pan PI3 kinase inhibitors had toxicity, which really limited delivery of the drug to such a degree that although there were suggestions of benefit, these drugs never were able to move on past the phase 3 sort of initial registration studies. We also looked at a more specific PI3 kinase inhibitor that targeted both alpha and delta isoforms, and again, toxicity really limited any evaluation of efficacy. However, in all of these earlier trials, what was seen across all the studies was that the benefit seemed isolated to patients whose tumors had PIK3CA mutations. So alpelisib is an alpha-specific PI3 kinase inhibitor, and you can see that it targets the alpha isoform shown in this cartoon. And in a phase 1b trial, alpelisib and fulvestrant had a 9.1-month median progression-free survival in the subset of patients who had PIK3CA mutations. And these were heavily pretreated patients. One of my patients who received fulvestrant, had not received fulvestrant before, received it in the third plus line setting after everolimus, so 18 months on everolimus and exemestane, then no ESR1 mutation, went on to alpelisib and fulvestrant in this phase 1b trial with new liver metastases, extensive metastases, had a CR for 4 years. So clearly this can be very effective, and we've seen data now in the phase 3 trial that validates the finding in that particular patient. So the most common somatic mutations occur in hotspots of the P110 alpha subunit, as shown here, and the specific subunits where the hotspots are shown in red. And this is important because you can see very, very rare mutations that may not be associated with response to this alpha-specific PI3 kinase inhibitor. I have to say, I have not seen them. I almost always see patients who have the E542 mutations, and I don't see the H very commonly. It's actually kind of interesting because it's listed as being almost 15% in the kinase domain. Now, it doesn't mean that you couldn't try a PI3 kinase inhibitor in these patients. We just don't have the data because they weren't allowed in the clinical trial. So SOLAR-1 was a phase 3 registration trial that evaluated alpelisib, as you know, and the trial was done as everybody is eligible, but you need to have the PIK3CA mutation status known ahead of time, although this was not used in order to define treatment. It was used for stratification, so patients basically went into one cohort or the other based on their PIK3CA mutant status. They were then randomized to receive fulvestrant with either placebo or alpelisib, and the two arms were identical, just less patients in the wild-type group. They were stratified by whether they had a CDK4/6 inhibitor before, but only 6% of patients had it due to when the drugs were approved, and whether they had liver or lung metastases. And the primary endpoint was locally assessed progression-free survival in the mutant cohort with multiple other secondary endpoints, as you would expect. So as you know, of course, because of the approval of alpelisib, progression-free survival was markedly improved from 5.7 to 11 months in the patients who had a PIK3CA mutation and who received alpelisib compared to placebo along with fulvestrant. What you can see is the hazard ratio here is 0.65, and this was highly statistically significant. Here's the 6% with prior CDK4/6 inhibitor. And in fact, although this was sufficient to lead to regulatory approval, we also had been able to look at cell-free DNA in this patient population. And this very nice slide that we had presented in San Antonio in 2018 compares actually here patients who did not have a PIK3CA mutation in tissue versus plasma and those with a mutation in tissue versus plasma. Here is the PFS benefit in patients who had PIK3CA mutations found in plasma. So what you can see is here's the plasma. It goes from 3.7 to 10.9 months, hazard ratio 0.55. So it's pretty good. I mean, the numbers are smaller. So really what you want to see here is that the total number of patients who had blood that was evaluable is smaller than the total population. The percentage that were positive is almost identical to tissue. But when we've gone back and looked at this, it appears that there are some patients who have mutations in the tissue where it's not found in plasma simply because there isn't enough cell-free DNA. So what we usually do is screen with plasma. We send off cell-free DNA, and if it's negative, we then go and look in tissue. Now, many of these patients have already had NGS done in tissue for other reasons, and so we have the data already, then there's no reason to send cell-free DNA. Based on this, actually, alpelisib is the first and still only approved drug in breast cancer that can be used based on cell-free DNA data alone, where you don't need tissue data, and there is a biomarker that predicts response. Looking at progression-free survival by subgroup in the PIK3CA mutant subgroup, you can see that pretty much everybody benefited. All of those diamonds are to the left of one. The patients who were classified as having endocrine-sensitive disease, there were only 39 there down here, so you really can't really assess this. But for all the subgroups here, whether or not patients had visceral disease, you can see that the benefit appears to be identical, and it was a 50-50 split here, so this is a pretty good number of patients. Bone-only disease patients benefited. 20 patients had a prior CDK4/6 inhibitor, and I'll show you more results on that in just a moment. And even interestingly, prior chemotherapy didn't really seem to affect this. It was all given in the neoadjuvant and adjuvant setting because we didn't allow chemotherapy in the metastatic setting. So we also looked at the exon. So is it exon 9 or exon 20 and the mutation subtype? And you can see these just all line up. Everybody benefited from alpelisib. The overall response was also improved. Here's all patients and the subset of patients who had measurable disease, as shown here, and this was statistically significant in both groups. And then we recently saw data at ESMO in 2020, just hot off the press in Annals of Oncology this year, showing that the median overall survival, although not meeting our pre-specified O'Brien-Fleming efficacy boundary, did have a numerical improvement, which is a really interesting thing, and it has to do with powering of the trials, how many patients you have in the trial. So 7.9-month difference. Interestingly, in the Bolero 2 trial, the difference, I think, was about 4 months in overall survival. I think it went, I think the difference, or it might have been 8 months, actually. I have to go back and look at it, because it was one of those similar things where the p-value was not significant, but the number was so big. So here it's 7.9 months, but the p-value was less than 0.0161. And so the p-value here, one-sided, is 0.15. So it really in no way meets statistical significance. And the hazard ratio is 0.86 with confidence intervals crossing 1. What's interesting in the way you look at absolute differences is this is through Kaplan-Meier, right? And you can see that the curves separate at various times. But overall, based on everything we know and the way censoring is done, you can see heavy censoring late out here, there is no difference in overall survival. But if you look at patients who had lung or liver metastases and time to first chemotherapy, you really do see a difference, which I think is clinically important. Although, again, hazard ratio drops to 0.74 here, the confidence interval still crosses 1. You have about 90 patients in each arm. But here you can see that there's actually a really substantial difference here in terms of overall survival. Clinically, again, this is a numerical difference going from 25.2 months to 34.4 months, which I think, again, clinically important to knowing that you're not having any adverse effect on overall survival in our patients with the worst prognosis disease. And then the median time to chemotherapy delay of 8.5 months was statistically significant. Hazard ratio of 0.72 didn't cross 1 here. And I think that that's very comforting for us when we give an agent that has toxicities that we need to manage. Updated adverse events were shown at the overall survival presentation at ESMO, so I'm sharing those with you today. There really were no new signals. The biggest issue is hyperglycemia, rash, and then diarrhea. And really the way you want to look at this is you just go down the grade 3, grade 4 toxicities to try and understand this. There are some other toxicities here, such as stomatitis. It's worthwhile mentioning stomatitis specifically because you can completely prevent this by using a steroid mouthwash similar to what we use with everolimus or a steroid dental paste. The big issue here in terms of patients is screening for glucose, and we'll talk about that more. You know, the glucose control was hard. We as oncologists are not great about controlling hyperglycemia. 33% of patients, really 35% overall, had grade 3, 4 hyperglycemia. And then rash in 10% was grade 3 and can be difficult to control. Prophylaxis for rash is very important, as we'll talk about in a moment. The other thing just to mention to you is the weight loss. So about, you see here about 28% of patients had all grade weight loss and 5% grade 3. This is almost always associated with poor glucose control. So if somebody's really losing weight, think about how their glucose control is going because that's going to be really important. So I'm showing this slide as this was from the original SOLAR 1 trial, but just to tell you that 25% of patients discontinued alpelisib due to toxicity, and interestingly, 6.3% due to hyperglycemia and 3.2% due to rash. And no patients, of course, discontinued placebo for either of these. So this is actually really important to understand, and again, we'll talk about it a little bit more. Is there any difference in the safety profile by geographic region? This is actually really interesting, and it does appear that in Asian patients there may be some increase in rash, and that's the specific one you can see here. Hyperglycemia is interesting because I think when patients are overweight, we're more likely to think about hyperglycemia. In the Asian population, we do see hyperglycemia even in very thin patients, so this can be a real issue and something that it's very important to screen for, as we'll talk about in a moment. We published data last year looking at the time course of adverse events in SOLAR 1. I mentioned hyperglycemia, rash, and diarrhea were the most common grade 3 or greater adverse events, but the time course is fascinating. The median time to onset of hyperglycemia and rash is the first 2 weeks, very fast, whereas diarrhea can occur anytime during the course of treatment, and you're more likely to see it in patients who've been on for a long time, so it's important to keep in mind. The hyperglycemia levels out, obviously, early on, and the median time to improvement is shown here. It's relatively quick for hyperglycemia and short for rash. When you stop the alpelisib, it's really important to keep in mind that the glucose, if those patients were not diabetic when they started out, their glucose rapidly returns to normal. So if you have them on a bunch of hypoglycemic drugs, you want to stop those as soon as you stop alpelisib because you will end up making them hypoglycemic. We've seen in almost all the studies now that using prophylactic anti-rash medication can markedly change the incidence of rash and the grade of rash. What you can see here is these are patients who took prophylactic anti-rash medication. Here's the number with no events in red. Here's the group who didn't take any prophylactic anti-rash medication. We use antihistamine prophylaxis and start the day before they start the alpelisib and use twice the recommended over-the-counter dose of antihistamines. And here you can see that we really halved the rate of grade 3, 4 rash as well. Again, as I mentioned, the steroid mouthwash is great if patients get grade 1, 2 stomatitis. And then keeping the drug exposure can be very important. As you can see here in this post hoc analysis, we looked at patients based on having a dose intensity of at least 248 milligrams versus less than 248 milligrams. And you can see the median PFS appears to be somewhat shorter with the lower dose. The full dose is 300 milligrams. So we usually go from 300 to 250. So you get a 150 and a 100, and then you can keep going down from there. But what's important is that once patients tolerate it and you're managing the toxicity, you should go back up on the dose again. And then, interestingly, once we educated our trial colleagues, so we did all these webinars about halfway through the trial because we noticed that there was a lot of discontinuations that we thought we could potentially avoid. We found that the toxicity actually decreased. And the way we looked at this toxicity, which was difficult, was discontinuation due to any grade event. And what you can see is that before and after the education, discontinuation due to any grade went down to 3.6 versus 9% before we did the education, more than a halving. And discontinuation to grade 3-4 events went from 5.6 to 2.9%. And even the incidence of high grade events, although overall grade didn't change, the incidence of grade 3-4 events significantly decreased. And this is for hyperglycemia specifically. And I think that's really important because hyperglycemia can be quite difficult to manage. So it does appear that education and knowledge about the toxicities and prophylaxis is really important. So provider and patient education is critical. I think all patients should receive prophylactic antihistamines to prevent rash, and they have no toxicity, so that's great. A baseline hemoglobin A1C and fasting glucose is recommended. Patients who have a high hemoglobin A1C, even a slightly above normal, may have hyperglycemia. It's quite likely. You should check a glucose on day 8 and day 15. Some people start metformin proactively in those patients, and it's important to partner with an endocrinologist in order to add additional medications. We try and use insulin last, as there's some data that suggests that it may, to some degree, abrogate the effectiveness of alpelisib. We don't have true clinical data on that. And then inform patients about the risk of diarrhea and importance of taking loperamide and also reporting diarrhea that occurs, because this can be a late phenomenon. We've been very interested in trying to understand how alpelisib works in patients who'd received prior CDK4/6 inhibitors, and so we did the BYLieve trial. This trial, cohort A, was presented at ASCO. The paper is now in press, and cohort B was presented at San Antonio. We also have a third cohort shown here, and these trials basically is a non-randomized open-label phase 2 trial, and patients enrolled in cohort A, their immediate prior treatment was a CDK4/6 inhibitor and aromatase inhibitor, and they all received alpelisib and fulvestrant. In cohort B, their immediate prior treatment was CDK inhibitor with fulvestrant, and they received alpelisib and letrozole. And then the last cohort are patients who received chemotherapy in the metastatic setting. All patients have a centrally determined PIK3CA mutations, although you could enroll based on the local results. A small percentage of patients are not in the final analysis because they were not found to have a mutation on central testing. Our primary endpoint was the proportion of patients alive without progression of disease at 6 months by RECIST. And then we have a number of different secondary endpoints, including progression-free survival and safety. I'll just show you the primary and endpoint and progression-free survival here due to time. The primary endpoint was met in cohort A with prior AI and CDK4/6 inhibitors last treatment. 50.4% of patients were alive without disease progression at 6 months. The median progression-free survival was 7.3 months, which is quite encouraging, and you can see the progression-free survival curve there. 44% of patients in SOLAR-1 who had received a prior CDK4/6 inhibitor were alive without disease progression at 6 months, so I think this compares favorably, although remember that was only 20 patients in SOLAR-1, so it's really a tiny population. We did a real-world comparison with a Flatiron database. This Flatiron database included patients who had PIK3CA mutations, although obviously not centrally determined. And we looked at PFS with whatever treatment that they had received after an AI and CDK4/6 inhibitor. And you can see that regardless of the type of matching that was done, the PFS are relatively similar, and it's always better with the addition of alpelisib. All of these patients received some therapy after an AI and CDK4/6 inhibitor. It included fulvestrant in combination with different agents, even capecitabine in this patient group. So I think this is fascinating data and excellent use of real-world information. BYLieve cohort B, as I mentioned, included patients who had received prior fulvestrant and a CDK4/6 inhibitor as their immediate prior treatment, and 82% of those patients had progressed on a prior AI. So they all had AI-resistant disease, but 46.1% were alive without disease progression at 6 months, suggesting either that alpelisib has single-agent efficacy or it can reverse the resistance with the AI. These patients received letrozole as their AI. The median progression-free survival was 5.7 months. And I think that's really exciting because in our patients who've already received an AI and progressed, it suggests that you can still have almost a 6-month time of median progression-free survival before you have to go on to chemotherapy, which is usually the next step in these patients. And you can actually further get mileage out of an AI in the PIK3CA mutant cohort by adding alpelisib. So in summary, alpelisib is an alpha-specific PI3 kinase inhibitor. It improves PFS added to fulvestrant in patients with hormone receptor-positive PIK3CA mutant metastatic breast cancer. There's a numerical improvement in overall survival and a suggestion of enhanced and improved survival in those with visceral metastases. It's effective after progression on CDK4/6 inhibitors, regardless of the prior endocrine therapy, and it appears to add benefit even in patients with resistant to AIs when added to letrozole. The toxicities are very, very important for alpelisib in a way that's not so important for the CDK4/6 inhibitors, with the exception of diarrhea from abemaciclib. But here, hyperglycemia is really our biggest challenge, with rash close behind. It's really important to use the prophylaxis for rash and to stay on top of the hyperglycemia as much as possible. There is a subset of patients who will not tolerate alpelisib. I recently had a patient who developed swollen lips and a rash. No matter what I did, I just could not have her tolerate it. She actually is tolerating everolimus very well. So I think that if you run into a patient like that, she's the first patient I've seen who I could not get around the rash in the many patients I've treated. And this swelling of the lips was very unusual. In those patients, you can use everolimus. There doesn't appear to be any cross-reactivity in the toxicity. And then diarrhea can be managed late. Remember that dose reductions and dose holds are ways to manage the hyperglycemia and rash up front. It's really important not to continue the drug when patients develop significant rash because it will just get worse. So you want to hold the drug and restart at a lower dose. The same with hyperglycemia. You want to manage the glucose. Where we've seen problems is patients who had a high hemoglobin A1C and glucose, but not enough in normal life to get treatment. They start on treatment, nobody checks their glucose at day 15, and then they come in with acidosis and have to be admitted for hyperglycememia. So you just really want to stay on top of it and work with your endocrinologist. Now that we have e-consults, it's been a lot easier. I don't know how available those are in Egypt, but it is really important because the newer hypoglycemic agents can provide a lot of benefit in these patients. The other place where we really have to educate the patient is diet, and that can be a huge challenge in patients with metastatic disease. But to try and use these low carbohydrate diets really plays a very big role in controlling the glucose. And there are studies ongoing looking at diet as a primary mechanism of controlling hyperglycemia in these patients. With that, I'll thank you very much and show you some pictures from Northern California. Of course, the color is all due to pollution and smoke, but it's still quite beautiful. Thank you for your attention.
Thank you very much, Professor Hope, for this wonderful lecture. Before we let you go to your patients, I've got 2 questions to ask you. Very quick. When do you test for the PI3 mutation? Once the patient becomes metastatic, and would you do it on the tissue? And if the tissue has been there for a couple of years in the archives, do I need new tissue, yes or no?
Great question. So I test when I'm getting closer to wanting to treat with a second-line endocrine approach. So I think that, I don't test for ESR1 mutations up front. I use the patient's disease-free interval and their response to endocrine therapy as the primary indicator. So I wouldn't do, NGS simply for that purpose of an ESR1 mutation. And because I'm going to treat patients up front with a CDK4/6 inhibitor, I don't think the NGS is all that useful to detect the 2% of patients who have RB loss, because we may treat those patients anyway. I've had a patient respond who had RB loss, but it was in blood, cell-free DNA, and it was like 0.3%, and clearly that wasn't affecting her response to CDK4/6 inhibition. So really where I tend to test is, partway through their treatment with the CDK4/6 inhibitor. If they're going to stay on that drug for 6 years, you don't need to do your NGS up front and spend the money. In terms of the archival tumor tissue, this is really important because PIK3CA mutations are actually conserved, meaning that it's kind of even more so than HER2 probably, that if you have it early on, it stays, it doesn't go away, whereas ESR1 mutations come and go, but PI3 kinase mutations don't. So if you look at archival tissue and you have a mutation, you can feel pretty confident in using that. If you don't have a mutation, there is a percentage of patients who acquire mutations with treatment, and for those patients, it's probably worthwhile to either check tissue or blood in the metastatic setting, and that's our usual approach, because you will capture a percentage of patients who did not have it in their original tissue.
So,
I don't think it really matters if the tissue is 10 years old even, because these DNA mutations are also easy to find even in old tissue.
So if I don't get a positive test on the archival tissue, you'd prefer that I go on to something like circulating tumor DNA. If that's negative, then go and try and get some fresh tissue from the metastatic sites.
Yes, and of course, if somebody has a node or something, it's actually fairly easy to biopsy the node and do the testing. The problem is that a lot of these patients have bone-dominant disease, as you know, or they have like a single lung nodule. You don't want to biopsy with a core. And bone is a problem, because if you decalcify it, you really have a much reduced chance of finding what you're looking for. So if a patient has, extension of soft tissue outside the bone, that's one thing you can biopsy. Sometimes I'll work with my pathologist to try and tease out the cells from the block, from the bone biopsy, and test that rather than using the decalcified block.
All right. So the second question is, if I'm right in your sequence of a hormone receptor positive patient with a PI3 kinase mutation, it would be CDK4/6 followed by a PI3 kinase, and when that fails, I can go for an mTOR inhibitor.
Well, we don't know what the effectiveness is of using a PI3 kinase inhibitor then an mTOR inhibitor, and I think it's an interesting question. I have some data on mTOR followed by PI3 kinase inhibitors in patients with mutations where there was efficacy in a few patients I've had. I don't know about the alternate sequence, so it's something you could absolutely try. We're hopeful that we'll have oral SERDs in the future that will actually be able to potentially work in patients who have resistance to fulvestrant. And then also there's a whole area of study looking at other agents, these SERCA, so selective estrogen receptor covalent antagonists, as well as a SERM, lasofoxifene, that's being studied in patients who have ESR1 mutations and may have some efficacy in the later line. So we're hoping there's a whole nother area of study looking at SARMs, selective androgen receptor modulators. We may have agents in the future that work in this later line setting. But I would keep in mind that tamoxifen is a good agent still. You have to look for clots, of course, and exemestane can certainly be tried in patients as well in this later line setting. There is, as I mentioned in the talk earlier this morning, earlier, I guess today for you guys, is that there's some very, retrospective kind of data on efficacy of CDK4/6 inhibitors after CDK4/6 inhibitors, and I think that's an interesting area as well to consider.
All right. Thank you. And to everyone who's watching us online, Dr. Hope is going to be with us tomorrow morning for a Meet the Expert session. So please send in your questions. We'll be giving them to her tomorrow morning. And thank you, Dr. Hope, and we'll leave you to your patients.
Thank you, and see you tomorrow.
See you tomorrow. Dr.
Bye-bye.
Ahmed Hassan, you have, after this wonderful talk from Dr. Hope, a case and a talk for us on premenopausal patients, right? Would you like to go ahead with that one? So this is all about premenopausal patients. As I said, we always thought that premenopausal patients should be treated somewhat different from postmenopausal patients, but I think especially in this, in the era of controlling the hormonal cycles of females and how well we're doing it, I think Professor Ahmed is going to give us a different perspective on that, right? Ahmed, please. Well, this is the first question. What are the phase 3 trials dedicated to premenopausal patients? Because it's all well and good to say that, yes, we can get these patients to become, in sort of the hormonal essence or the estradiol level, to become postmenopausal, but do we really have trials that are dedicated to these premenopausal patients?
Well, it was very important to devise a clinical trial looking at this very distinct group of patients. We didn't have any pure data on the premenopausal patients before. Why it is important? Because actually breast cancer is the most common cancer in this age group.
Yeah.
That's one thing. The other thing is that it's a very distinct group of patients in many aspects. The disease is more aggressive, breast cancer mortality is higher, disease-free survival, progression-free survival, overall survival are worse. These patients tend to come with more likelihood of visceral metastasis, higher volume of disease, more aggressive features.
And
Moreover,
they're obviously the bigger part or portion of our patients in Egypt.
exactly,
Professor
yeah,
Mohammed, you agree?
and
I think we have a challenge besides the effect of treatment. We have working ladies in this age.
Yeah.
So we have to mention that the quality of life with CD46 is quite important, more than giving chemotherapy early.
in fact, I mean, if we look at the Egyptian census, the most recent Egyptian census, you'll find that 89.5% of Egyptians are younger than 54 years old.
Yeah.
So by definition, almost 90% of Egyptian ladies are premenopausal.
Yeah.
So this is very, very relevant to our practice here. And that's why personally, for example, I was very enthusiastic when I've known that the complement study will be open here in Egypt, but unfortunately it was open to recruitment and closed before we were able to include patients, but they included patients from other parts of this region. So it is a very, very peculiar group of patients, and we haven't had any pure data on them. We've had, yes, definitely we've had some data from the other CDK4/6 inhibitor studies, but they were subgroup analysis.
All subgroup analysis,
Yes,
right.
yes.
And can you show us some of that data on the Mona Lisa 7?
Yes, here I just wanted to demonstrate how these patients are different. They are not only different in terms of prognosis, but they are also different in terms of the biology of the disease. They are different in their needs.
Yeah.
They have different lifestyles. They are very active. They have young kids. They have their career. They're doing some studies. They're doing more households. So they want to carry on with their active life as long as possible. And quality of life is of paramount importance. There's also another thing that we did not know well about these patients is their compliance and adherence to treatment. We've known from studies on the adjuvant setting that they are less compliant, less adherent to their treatment.
Yeah.
So that's another thing that was possible to review in the Mona Lisa 7 study. So this slide summarizes how different this group of patients are.
And that's why I'm saying, if we induce artificial menopause in a lady that is premenopausal, why would we expect different results from a postmenopausal patient? But it is a different patient. I don't think we are expecting different results, but we are expecting that this is a totally different patient. You said the psychological element, that's one, and the vigorousness of the disease being a more aggressive disease, a more difficult to control disease than a patient that is postmenopausal. I think everyone here would agree that premenopausal patients disease is definitely slightly more difficult than the patient. But if we do induce menopause in that patient, why is she different, or why are they still different?
Well, the common perception among many oncologists and many physicians is that it should be the same. If you are inducing artificial menopause,
Yep.
medically or surgically or by radiotherapy, then you've switched the hormones off and then you have a similar profile of patient. But in fact, this is not true, because we know that age per se is an independent risk factor. And that's why, for example, in our daily practice in the adjuvant setting, when you judge upon giving chemotherapy, you don't only look at the premenopausal status, you look at the age of the patient. We have good data to support this. Another piece from the earlier cancer setting is the adjuvant ovarian function, the text and the soft studies. The text and the soft studies, when they looked at the subgroup of patients who benefited more from ovarian function suppression, they found, by definition, they were all premenopausal in these studies.
Yes.
But they found that those younger than 35, yes,
exactly.
they benefited more.
And we have a good bulk of our patients that are actually in that group of 35 to 40. I think that's
Exactly.
great.
Which brings two questions to mind.
Yeah.
The first one is, why is this happening?
Yeah.
And we don't have clear explanation to this. Some say that it probably because of the likelihood of familial genetic predisposition, that is, increased likelihood of BRCA mutations.
Yeah.
Others say it's because they are more luminal B than luminal A. So this is another, but they are all theories. We don't have a definitive answer. The second question is, what is the definition of young age?
Yeah.
At which point things significantly change? I'm bringing here a study which looked at what could be this mark or this bar. This is Swedish data. They went back to their records back to 1970s, and they looked at patients and whether age plays a factor or not. They looked at more than 4,000 patients. And as you see, they underlined a group of patients at 10 years, those who were younger than 40 years of age, they had 40% decreased risk of breast cancer mortality. This was statistically significant.
That totally says the aggressive. I think that's totally the aggressiveness, because they probably all sort of received the same type of standard of care, whether it was anti-HER2, anti-hormonal therapy, or chemotherapy, and as well as, of course, the radiation and the surgery. But this, I think, stands out as being age totally different.
Yes,
Professor Mohammed.
I think concerning the biology of premenopausal breast cancer is completely different biology from postmenopausal. I think we put the age of sequencing because we have a patient with 80 years old. We have no time for sequencing.
Yeah.
But in a premenopausal patient, by the age only, you have started to postpone as you can the giving chemotherapy, and you have a
So
no time.
that's
for
another
sequencing.
factor. You've
Yes.
got time to
Yes.
or you want time, more time for this patient to be in sequence. Ahmed, please carry on. Thank you. The third question is, as you said, these patients have a more aggressive disease, so obviously they've got visceral disease. Now, visceral disease is, as perceived by a lot of physicians, and even from the prior lectures that we were hearing on breast cancer in the prior session, they were talking about if this is eminently distorting life or eminent for death. These are the patients that they would give chemotherapy. They've gone from that visceral crisis sort of thing, which I'm sure you agree, nobody has a definition for visceral crisis. But these young patients are sort of tend to have more visceral disease involvement,
Yes.
as you said. Would that be more inclining for me to give them chemotherapy because they're young, they can tolerate chemotherapy, they have visceral disease, and I need to get a quick response? Do I think nowadays, from 5 years back, should I be thinking different for these patients?
Yes, definitely. And I would want to capture what you've said, the statement about the quick response. This was our main concern. what we know that endocrine therapy in hormone receptor positive patients, you will attain a good response. And you will attain reasonably long duration of disease control. But most of us in the past, we were more inclined to offer chemotherapy. This is a young patient, very young patient, and she's coming with liver or lung metastasis.
Yeah.
We are uncomfortable waiting for responses for hormones because data tell us that the nadir response you witness with endocrine therapy takes from 3 to 12 months.
Yeah.
So you wouldn't want to miss the boat. So most of us used to prescribe chemotherapy up front to gain good control over the disease, and then you move on to endocrine therapy when you are more relaxed. But now things are different. I mean, with the increasing data from the CDK4/6 inhibitors, and particularly from the MONALEESA 7 study, you can see that actually you can attain responses as quick as 6 to 8 weeks, which is very similar to what we see with chemotherapy.
Yep.
But add on the improved progression-free survival. We know that with best chemotherapy regimens, you get a progression-free survival of 12 months with chemotherapy. Dr. Huprogo published 3 or 4 years ago the results of the cancer and leukemia group study, which looked at taxanes plus or minus bevacizumab, and we've seen progression-free survival of 12 months, which is the same as with letrozole or aromatase inhibitors alone. Now we're seeing from these studies, and I'm quoting here the MONALEESA 7 study, the response rates seen at 8 weeks, similar to chemotherapy in visceral metastasis. And we have the earlier data from 2017 when they demonstrated that progression-free survival with visceral disease was significantly, clinically and statistically significantly improved. We see here 10 months to 24 months in visceral disease. In the San Antonio, in the ASCO this year, or last year to be precise, they showed that in visceral group there was an overall survival improvement, and when they looked at liver-only metastasis, the overall survival was even more profound. So
this, just for our audience, this is from the MONALEESA 7 purely premenopausal patients, younger patients or younger group of patients with that visceral disease. Professor Muhammad, do you agree that today a patient with liver mets not having a life-threatening impending disease, you would go for a CDK4/6 or in this case ribociclib plus hormonal therapy for these patients rather than chemotherapy?
Yes, I think after releasing of MONALEESA 7 and all of the trials of CD46 inhibitor become mandates to start with CD46 inhibitor because you are postponing chemotherapy. To the clinical practice, all of premenopausal women may have chemotherapy after failure of CD46 and alpelisib fulvestrant. So as if you are trying to postponing giving chemotherapy, are hitting a very good target.
And we're getting a progression-free survival from this of how long?
2 years.
2 years. So we're doubling the progression-free survival that we got from what Professor Hope was presenting on the chemotherapy of 12 months. So we're doubling that to 25 or 24 months. Please, carry on.
I'll give you another example. Many of us, including myself, was very big fan of capecitabine in these patients.
Yeah.
So we have data from the Ribbon study. The Ribbon study, it was a phase 2 study which looked at bevacizumab, capecitabine plus or minus bevacizumab. And the superior arm, which is the combination arm, the progression-free survival was only 8 months.
All right.
So we can say actually that
I think it was long known that chemotherapy doesn't really work
Exactly.
in hormone receptor
Exactly.
positive patients. It doesn't work that as
Yes.
well. But this is obviously data to concise that. So this 5 years that we've seen as an overall survival, how significant is it? Because we are going to prescribe something that is sort of out of the box for our physicians here. These drugs, whichever CDK4/6, are sort of new to the market. You might have some toxicity that you want to avoid. Some patients might be familiar with chemotherapy, And obviously it is slightly more expensive than chemotherapy, especially if we're talking about single agent like capecitabine. But having 5-year survival data or overall survival data sort of makes me confident that I can give it. And the second is, how do you convey this to your patient? How would you describe this to your patient in terms of 5 years overall survival?
5 years is a very long duration. Actually, we've seen the world change 180 degrees in 1 year. So, yeah, exactly. So 5 years is a lifetime for others. And
Yes.
I'll tell you a little story. Last week I had a patient of mine. She's 42 years old. She's an engineer. Saw her only once 5 years ago. She walked in with her husband and 3 kids. And she was coming to take second opinion regarding adjuvant treatment. Then I saw her last week. She's coming with a bone scan showing widespread bone metastasis. So I told her, where have you been in the 5 years, past 5 years? She came with her father. She said, I got a divorce from my husband. The kids are now in high school, in secondary school. I started a new company, a new engineering company, consultancy company. So I told her this happened throughout the past 5 years, right? So what do you want to do, carry on doing in the next 5 years? She said, now with this result, I'm not looking for anything. I'm just waiting for my fate. So I told her, no, that's not right. What are your major concerns? She said, chemotherapy and loss of hair.
Yes.
So I told her, listen, we have alternatives and things have changed, the practice has changed. Then we discussed the different alternatives and fulvestrant and CDK4/6, hormone therapy alone versus combination with the new classes of treatments. So she went completely with a different impression than what she came in with. So we're opening new gates of opportunities for our patients now.
I want to take you on one thing. You said she came in with a bone scan. The prior lectures that they were talking about whether or not a patient like this you would give a CDK4/6, yes or no, or just give fulvestrant as a single agent. She's got only bone met. But I think, especially in this young group of patients, I think CDK4/6 is warranted rather than giving single agent fulvestrant, even though the data of the Falcon trial is obviously positive. But I think a CDK4/6 is a must in these younger patients. Do you agree on that?
Yes, I do agree, and I have another reason also to think of keeping fulvestrant as an active, valuable agent until later.
After.
We were just talking about the data of alpelisib,
Yeah.
and the approved combination with the alpelisib is fulvestrant.
Would you also test this patient for PI3 kinase mutation?
I would,
Yeah.
definitely I would. Yes.
Dr. Martha, I think we are talking about survival, but forgetting in some situations quality of survival.
Yes.
Says it's very important to qualify quality survival of the premenopausal patients with tablets-wise CD4/6 inhibitor plus hormonal treatment instead of giving her chemotherapy. So it's a very
like
good,
Ahmed said,
good
the
point.
first thing was loss
Yes.
of hair. I
Yes.
think is very important. Please carry on. I think.
So these are the data from the ASCO, showing the overall survival improvement.
This is around 11 months difference in overall survival at 5 years. So I think that's sort of another year to the overall survival.
Exactly. So we can now say that what you have gained upfront with the first line of CDK4/6 inhibitor, you were able to retain until the end of the 5 years in terms of overall survival.
Thank you very much,
Thank you.
Professor Ahmed. And I think we've got Professor Mohammed Sabri next. He is going to be giving us a talk on postmenopausal patients, right?
Yes.
Professor Mohammed, please go ahead.
I'll speak today about postmenopausal patients using upfrontly fulvestrant plus ribociclib in the first line. I think we are defining the impending vessel crisis as a definition of circumstances of disease. I think we have debates about impending vessel crisis. We highlighted in the last ABC and failed to define this a critical situation to start with. And also, I think visceral crisis in some patients you cannot give even chemotherapy.
I totally agree with you on that, because when they say visceral crisis and you have a bilirubin of 3,
Yes.
where are you going to give chemotherapy? When you have a patient that is impending to get onto a ventilator, why or how could you be giving chemotherapy to that patient? Yes, please.
Yes. So I think the impending vessel crisis is the definition will be highlighted in my case to put the CD46 inhibitors in the right position, because if you pick the patient in the certain circumstances, you can pick it away from the visceral crisis. So I will present my case today. It is she's 65 years old patient, presented to me after 1 year of completing 5 years of adjuvant treatment. She presented with massive left pleural effusion with lung collapse. Workup showed single hepatic focal lesions and massive left malignant hemorrhagic pleural effusion. The biopsy confirmed that the patient still luminal type A breast cancer, and the patient hospitalized because she was desaturated and admitted to the intermediate care unit to put intercostal tube. So in this very critical situation, you can see that it's very risky to start with chemotherapy, and you should think about any alternative. So we have need in this case to abrupt or to stop the malignant process as fast as possible. But the patient, because her admission in ICU, you cannot give chemotherapy, because also this is not triple negative patients or HER2 positive patients. Still, you have patient of luminal type A and relapsed after 1 year of completion of adjuvant treatment. So she may be classified according to the Novartis 3 to be hormonal sensitive patients. So I think nowadays, after 5 years of releasing of data from all CD46 inhibitors and 5 years of clinical practice, I think the decision will be changed completely when we think about the chemotherapy as a front line for those patients. I will explore with you all trials done on the CD46 inhibitor. We have Monalisa 2 and Paloma 2 and Monarch 3, and Monalisa 3 trials passing through Paloma 3 and Monarch 2 and Monalisa 7. We have 4 main trials giving significant overall survival benefit. We have Paloma 3 and Monarch 2 and Monalisa 3 and 7. Those 4 main trials giving overall survival benefit for the patients with either second line or first line. But I want to highlight the Monalisa 3 trials starting with fulvestrant as upfront combination with ribociclib for a patient with de novo disease and patient with sensitive disease who progressed after 1 year of finishing their adjuvant treatment.
So you're talking about which endocrine partner to give with the CDK4/6. Would I give fulvestrant or would I give an AI?
Yes, I think both treatment options are good enough. But after releasing of Monalisa 3 trials, we saw that a patient with hormone sensitive and de novo patients achieving a significant overall survival benefit of 33 months PFS.
Yes.
So we have 2 choices. We can start with CD46 plus CI, or to start with fulvestrant plus ribociclib. But in my opinion, if you pick a patient with a hormone-sensitive patient, you have a very good chance to start fulvestrant plus ribo as a first-line treatment. Concerning patients with primary resistance, you can find that those patients are not preferred to start with ribociclib plus fulvestrant. You can start CD46 plus CI and postpone fulvestrant to be given as a combination with alpelisib after progression.
Right.
My patient today is, I will expose
and in this error, Professor Mohammed, would you test a PI3 kinase mutation to put that in sort of layering? So if I have a PI3 kinase mutation, keep the fulvestrant for the second line with the alpelisib and
yes,
shift
I totally
to
agree with you.
So you think maybe testing here would be...
the main benefit of predictive of PI3 kinase
yeah.
is to postponing fulvestrant to be given after failure of CD46, to be given with alpelisib.
Yeah.
This is the population of the patient in the Monalisa 3 trials. We have a very heterogeneous population of patients. We have patient progressed on an eye, patient de novo patients, and patient who early relapsed before 1 year of finishing of 5 year of adjuvant, and also patient who's late relapsed after 1 year of completion of adjuvant treatment. So those patients are concerning hormonal sensitive patients. You can see that about 50% of patients in malignancy trials, they are hormonal naive. They didn't receive any hormonal treatment for a metastatic disease. It's a very good point to take the patient of de novo patients and patient hormonal naive to start with fulvestrant plus ribociclib. Backing up to our case, the case, remind again, the case progressed after 1 year of completion here adjuvant treatment, 5 years. So by definition, she is hormonal sensitive patient, still hormonal sensitive. And as you see that the pleura is hugely congested and the total lung collapse. The patient at the time admitted to the ICU to put intercostal tube. PET-CT confirming the presence of also single hepatic focal lesion, but you know that this is not a visceral crisis, it's a crisis from serosal crisis. So the patient, by definition, has no visceral crisis, but she is in impending malignant crisis, non-visceral, but serosal. So after discussion, the treatment was very critical for the patient to start with chemotherapy at the time. She agreed to start the challenge, to start fulvestrant plus ribociclib as the first line. After 1 week, the treatment intercostal tube gradually stopped draining of hemorrhagic effusion. Within 2 weeks, the patient discharged to her home, and she improved dramatically within 8 weeks of treatment. You can see that some slides of this. You can see that on the right side, you can, after 8 weeks of treatment, you can achieve a very rapid response of fulvestrant plus ribo as if you are giving chemotherapy. On the right or left side, you can see that the X-ray before treatment. Also, the CT scan confirmed the regressive course. Within 8 weeks, you can see that the pleural sac is completely empty from any fluid accumulation. And by the way, the patient have a completely healthy lung. She have just a pleural sac. She has just a serosal effusion. So the PET-CT confirming that patient have marvelous response after 8 weeks of treatment. This is our challenge today, is to give safe treatment.
Professor Ahmed, even with chemotherapy, I wouldn't assess before 8 weeks. I mean, this is the assessment that was done at 8 weeks, and this was in the trial. That doesn't mean the patients don't start feeling response earlier than that 8 weeks.
Exactly.
I think it's just because we assess at 8 weeks or after 2 cycles. We are used to assessing after 2 cycles at least.
From personal observation, actually, with some patients, you start to see an improvement and a response after only 1 cycle.
And that's what I want to ask Professor Muhammad. Professor Muhammad, you gave this patient the CDK4/6 and the fulvestrant or ribo plus fulvestrant at that time. And she was in ICU, as you said.
Yes.
How long did it take her to come out of ICU?
She was in intermediate care just for pleural tapping. You know, that's hemorrhagic effusion.
But how long did it take her to feel much better?
2 weeks.
2 weeks.
2 weeks.
So and I think that's what's important. Don't think that it's 8 weeks. It's 8 weeks to to realize it on the scans, but that doesn't mean it's going to take 8 weeks before the patient starts responding.
Yes, I think you can see the PET-CT. The patient have a very significant response after 8 weeks of treatment. So keeping with data with realizing from malignancy trials that you can retain rapid response after 8 weeks of treatment. Yeah. So 70% of patients in ribociclib plus fulvestrant arm are gaining a tumor size reduction within 8 weeks. Also keeping with separation of PFS, we have 33.6 months PFS. Is a very unique figure of number of PFS comparing with fulvestrant arm only. We have also 28% relative risk of reduction of deaths in ribociclib arm plus fulvestrant, and after 42 months, about 60% of patients still alive and receiving treatment, comparing with 45% of patients receiving fulvestrant only. So even with visceral disease, we have a significant PFS and overall survival benefit for the patients.
Same as the premenopausal patients, exactly as the premenopausal patients.
Yes, yeah. The exact figure for malignancy 7, you can see the 20% reduction of deaths in the visceral disease and 38% reduction of deaths in the patient with liver mets. So I think we are only adapted with toxicity with CD46 because you know that it's completely different from the neutropenia from the chemotherapy.
Yeah.
I want to show this slide to compare with CD46 idea of neutropenia and chemotherapy idea of neutropenia. You can see that mechanism of neutropenia is quite different between chemo and CD46.
Yeah.
For CD46, we are arresting the cell precursors from work, but with chemotherapy, you are killing the precursor cells. So the neutropenia from CD46 are recoverable and can be corrected, and also dose reduction will not be negatively impacting the results concerning chemotherapy when you may delay the course.
Do I give GCSF? I think that's a question for our juniors. So if you get neutropenia, would you give GCSF if you're on CDK4/6, or just
No.
hold the drug? It will get back to
Yes,
its
you
own.
can hold the drug or decrease the dose, but
All
you
right.
cannot omit.
Don't give. No GCSF.
No,
Ah,
not recommended. So after 8 months, my message here, after 8 months, we pick the patient from a visceral or bending visceral crisis to be still alive with a very good quality of life and maintaining response with no chemotherapy given. Concerning this time was in COVID era in Egypt, and still we are, but very hard decision to give a chemotherapy in a very critical situation. As if you are able to give CD46 plus hormonal treatment, you are achieving better response and the quality of response and maintaining response with better quality of life.
Thank you very much. I think, having said that, I think the whole theme of having a 5-year overall survival, having new drugs that are biomarker driven like the alpelisib or the PI3 kinase coming into play for our patients, I think this is really important. Like you said, premenopausal patients probably different in biology, and that's why they need those CDK4/6s earlier on. And like Professor Mohammed said, they do give you good responses even very early on, and even sort of beating chemotherapy, if not as good as chemotherapy. Thank you very much, and thank you to everyone again who's watching us online, and we'll go to the next session. Thank you very much.
Thank you.
طب بص اقول لحضرتك خليك كده عشان ايه ابص على فين هنا اهو هنا ولا هنا
fantastic group of experts from Egypt, from your area, and from the whole world. I will have the great honor to start the meeting right after the lecture of Professor Tojo, the Nobel Prize for Immunotherapy, shared with other colleagues. And I will be talking about, on your request, the COVID situation. Dear colleagues, I'm certain this is going to be once again a great meeting in spite of the difficulties of the COVID times.
Good day, my dear colleagues. I'm so excited to be here at BGICC. in 2021. I wish I could be there in person, inshallah. In 2022, I will join Professor Hisham al-Ghazali and all my dear colleagues and friends in the Middle East and Egypt at the next conference. I'm thrilled that this year I'll be able to present some of our exciting work that we've done. God willing, that COVID will come to pass in the coming months and year ahead. And next.
Okay. Once again, thank you to all the audience that is watching us online and the audience that are with us here today. It's a great honor and pleasure always to introduce Professor Yasser Abdul Qadir, Professor of Clinical Oncology at Asr Al-Aini School of Medicine, Cairo University, my mentor and definitely the best thoracic